It's 16 o'clock and welcome to Clinical Journal Club in English. My institution has asked me to do a little advertising for the Experimental and Clinical Research Center, which is an interface between the Max Delbruck Center for Molecular Medicine, the Basic Science Institute, and our medical school. People that are interested in serious clinical research have a good home at the ECRC, and if this would meet your program, you're welcome to apply. In the New England Journal this week, we see this picture, and it's about a 41-year-old woman who presented to the eye clinic because her vision has been getting worse. And this is sort of a slit-lamp picture, and we can see that her pupil's been dilated, probably with homatropine or some other pharmacological compound. So her pupil's widely open, and we can see her cornea, and we're asked, what is this? Well, it's not herpes simplex keratitis because that's an acute disease and it looks quite different. This doesn't look like a foreign body or corneal injury. This is not vitamin A deficiency. So we're left with two procedures, and indeed these radial spokes that we see across the cornea here look man-made. This doesn't look like an illness. And there are two treatments for myopia that ophthalmologists use. One is laser-assisted in situ keratomileusis, abbreviated LASIK. That's the modern procedure. And the procedure from 1980s is radial keratotomy, and I'm certain that that's what this is. So this is radial keratotomy. This procedure isn't done anymore. These patients are at risk for progressive hyperopia and have other problems. So this operation has been abandoned. So if we briefly review the anatomy of the eye, the cornea is this translucent material labeled as 5. Behind that is the anterior chamber, aqueous humor. Here's the iris pupil. Here's the lens. Here are the canals of Schlemm. And this is vitreous material here, and the retina, of course, is in the back. So we're talking about a change that has to occur on the cornea. So we're concerned about corneal problems. This person here has had a traumatic injury with subsequent inflammation, looks entirely different. This is an excellent example of herpes simplex keratitis. This is an acute infectious disease that's very serious because the cornea can be destroyed in short order. And if we merely put a drop of fluorescein on the cornea and look at that under slit lamp, we can see these dendritic ulcers that are typical for herpes keratitis. This LASIK procedure that's done for myopia is outlined here. I hope this poor patient gets some propofol before this is done. This procedure does not appear to be beset with the complications that were earlier seen with radial keratotomy. That's shown here. An additional photograph of somebody that's undergone this procedure years ago. Looks like spokes from a wheel. And this is an example of vitamin A deficiency. Now, vitamin A is the eye vitamin, and it's responsible for a whole variety of things in the eye, including retinal function, and so that the cones work properly. And in vitamin A deficiency, there are these typical deposits on lateral to the cornea on the sclera. Looks like a foamy material. It's actually keratin that's formed here. It's associated with vitamin A deficiency, and these are called Bitot's spots, and they're typical. And I hope you'll never see any because we don't see vitamin A deficiency, at least not in this country at the present time. Now, the theme in the New England Journal, the first two papers are about malaria. And over half the cases of malaria in the world are Vivax malaria. And Vivax malaria, also called tertian malaria, is characterized by fever on one day, no fever on the next day, fever on the third day. So every other day there's fever. There's also a Quercian malaria, caused by P. malariae that's less common, where every fourth day is characterized by fever. Now with Vivax malaria, which probably involves over more than 1 billion people on the planet, the plasmodia are deposited in the skin, then they travel to the liver. This phase here is called a hypnozoite, and the organisms are stored in the liver. And when the malaria is treated, and Vivax malaria is still responsive to chloroquine, it doesn't really kill the hypnozoites. It merely kills the organisms that are circulating in the blood, so the patients get better. And then after several weeks, they have a relapse because the hypnozoites develop into liver schizonts, merozoites that are then released into the bloodstream, starting the malaria cycle all over again. Now, Vivax malaria has been around for millions of years, so it's adopted well to the host. And the parasite doesn't want to kill the host, because if the host dies, the parasite dies as well. That's the problem with falciparum malaria, which is more lethal and does not have this liver phase. But Vivax malaria and P. malariae and P. ovale, less common forms of malaria, have this liver phase, so that they're characterized by relapse. And relapse has to be handled differently than circulating malaria organisms. And that's what this story is about. Now, humans have learned to protect themselves from malaria, and one possibility is to have a mutated hemoglobin, hemoglobin S, and if you're heterozygous, you have hemoglobin SA, and these erythrocytes are relatively resistant to malaria. Another genetic strategy by human beings has been to downregulate an enzyme called glucose 6-phosphate dehydrogenase. And people that have less glucose 6-phosphate dehydrogenase are relatively resistant to malaria. But if they're homozygous, which can happen to women because the gene is on the X chromosome, or if they're males, then they have G6PD deficiency. They may be resistant to malaria, but if their erythrocytes are exposed to any sort of oxidative stress, they burst. That is a problem. Excuse me, I have a cold. So what we see here, glucose 6PD converts glucose 6-phosphate to 6-phosphogluconate, and that's then metabolized further to the glycolytic scheme. Now, when this reaction occurs, hydrogen is stuck onto NADP, reducing this material, which then in turn can reduce glutathione to restore glutathione to its reduced state, GSH. And GSH serves the purpose in erythrocytes to protect these erythrocytes from oxidative stress. And if there is no GSH, then these erythrocytes are prone to burst. And that's what this story is about. And there are a number of things that are found in nature, but also certain drugs that result in oxidative stress in erythrocytes and cause these erythrocytes to burst. Now, you won't believe this, but 1.5 billion people on Earth are relatively G6PD deficient. And this is a problem because when these people get hemolysis, they can quickly burst many of their erythrocytes so that their functioning hemoglobin drops from 14 grams per deciliter to 3. And they get into all sorts of problems. So again, that's the story, and it's worth reviewing again. Glucose 6-phosphate, glucose 6-phosphogluconate, production of NADPH, restoration of glutathione to GSH so that we're resistant to oxidative stress. Now, the gene for all this business is located on the X chromosome right next to the telomere. And that means that women that have 2 X chromosomes are only relatively G6PD deficient, unless they're homozygous, which is possible if their parents, one is a male that has G6PD deficiency, and the mother is a carrier, then they have a chance of being homozygous. That's shown here. But otherwise, most of the people that are at risk here are male because they only have one X chromosome, and if they carry any alleles with G6PD resistance, they're going to get them because they only have one X chromosome. Now, there are some natural substances that cause erythrocytes to be exposed to oxidative stress, and the most common of these are present in fava beans, or in German Ackerbohnen or Saubohnen. Now, I studied in medicine in Philadelphia, and in southern Philadelphia there were a lot of Italian immigrants. They loved fava beans, and since G6PD deficiency was very common, we saw this condition a lot when I was in medical school. So people of Italian origin learned to be wary of fava beans. But there are other materials that also classically cause G6PD deficient erythrocytes to burst, and one of them is primaquine. And primaquine has been around since 1926 and is active against malaria. And it's also active against these hepatic forms, so that it can lead to we call this a radical cure, where the malaria is not only cured in the circulating blood, but is also cured in this hepatic phase so that relapse doesn't occur. Now, primaquine is rather tedious because you have to take it every day for 2 weeks to enjoy a radical cure. So the people that you treat have to be compliant and actually take the stuff. Now, during the Second World War, the Americans noticed that a lot of their black soldiers, when they had to take primaquine, had hemolytic anemia. And that's how this whole business with primaquine and G6PD deficiency basically was discovered. Now, primaquine is rather tedious because you have to take it for 15 days, but tefenaquine is a compound that has the same pharmacological actions as primaquine, and it has a half-life for 15 days, so you only have to take a single dose. Now, the problem with this strategy is as follows. If your people are G6PD deficient and you didn't notice, and you give them primaquine, and they have a problem, you can stop the primaquine. But if you give them tefenaquine, once they've swallowed it, it's in there for 15 days, and if they have G6PD deficiency, they're going to get hemolytic anemia. So this is a problem. And then tefenaquine, and I believe primaquine also, is metabolized through CYP2D6, and CYP2D6 has a whole bunch of genetic variants that also influences the half-life that would have a bearing on the development of hemolytic anemia. This makes clinical research harder. And these two studies are remarkable because they had taken all this into account. So this is a comparison study to compare tefenaquine to primaquine in patients with Vivax malaria. And what was done here is young people were recruited, basically children, aged 16 to 18. And to be enrolled in the study, it had to be shown that they weren't G6PD deficient. So they had to have at least 70% expected G6PD activity compared to their population to be enrolled in the study, and they had to have a positive smear for Vivax malaria. Then the Vivax malaria was treated with chloroquine, and then in this first study they were randomized to primaquine, placebo, or tefenaquine to see if both tefenaquine and primaquine were effective in achieving a so-called radical cure. Believe me, it would be much easier to be doing immunoprecipitation, Western blots, throw on your sequencer and go home at 5 o'clock in the afternoon than to do this kind of research. So this is hard. And they actually had many centers here in Ethiopia, Peru, Brazil, Cambodia, Thailand, and the Philippines to conduct this very difficult study. So again, the people had to be between ages of 16 and 18. They had to not have G6PD deficiency. They had to have enough compliance to take the primaquine for 15 days. They had to come back to the physicians if they had a problem. So you had to have very compliant patients to do this kind of a very tedious study. So this is how that was done. And the primary outcome was freedom from recurrence, and that was defined microscopically, because PCR won't help you here. That will always be positive, probably, in people that have had Vivax malaria over a short period of time. So the positive endpoint here had to rely on P. Vivax parasitemia shown in a positive smear. And if we look at the data, we can see that the patients on placebo relapsed. So that at the end of 6 months, or 180 days, more than half of them had recurrence of Vivax malaria, presumably from this hepatic phase that wasn't adequately treated. But the patients that got primaquine or tafenoquine did much better than placebo. So both primaquine and tafenoquine beat placebo in terms of relapse from Vivax malaria. Adverse events. Well, they basically excluded anyone that had G6PD deficiency, so that really wasn't the problem. And then they were concerned about prolonged QT interval that we never even thought about in my days, but they did EKGs on these patients and nobody got long QT syndrome, so that's nice. And most of the side effects were tolerable, and it was obvious that the people that got primaquine actually took it, because primaquine actually looks a little better than tafenoquine in this study. Now, when we look at see what happens to hemoglobin, during the acute malaria phase, it drops in all groups, and then it comes up again, and then the two groups that got the radical cure did better than the patients that had relapse, who then again had to be treated with chloroquine for a second time to continue in this study. Now, you might think that male patients would have more of a problem, but again, since G6PD deficiency was ruled out at the onset of the study, that would seem not to be the case. So it looks like tafenoquine is an adequate substitute for primaquine, and the patients would only have to take it once and not take it for 2 weeks. And GlaxoSmithKline has agreed to make tafenoquine available for patients that need it. Now, the next study is exactly the same thing. Also is difficult, except here there is no placebo group. And the idea here is to show that tafenoquine is no worse than primaquine. And this was, again, a multi-center study, same design, same care, that the subjects didn't have G6PD deficiency, and all of this business that I've already told you. And this is how frustrating this study is. So they've found 369 patients with malaria, then they have to convince them to be enrolled in the study. And there were Ho Chi Minh City and Cambodia and Colombia and Brazil and Peru, etc. And then they were assigned to these various groups in the ratios shown here. And then there were some study that were patients that were lost to follow-up, or people that didn't take the stuff, and these various problems that we have in clinical research. Again, a drop in hemoglobin. Now, why this one group had a hemoglobin of 19 grams, I don't really understand that. But at any rate, there's a drop in hemoglobin during the acute malaria, but then there's recovery because all of the patients in this study got a drug that's associated, at least with a radical cure. And then the reticulocytes recover, and indirect bilirubin levels are elevated during acute malaria anyway, but there's a recovery here. And if we look at side effects, it looks like the compounds were pretty well tolerated. Excuse me. And long QT syndrome was not a problem. But if we look at the results here, primaquine actually looks a little better, and tests for the hypothesis that tafenoquine is no worse were not quite statistically significant. But it looks like tafenoquine is an adequate treatment which the subjects would only have to take once instead of having to take it for 15 days, where compliance is a major problem. And apparently, if you give these materials, you first have to test your patients to see if they're G6PD deficient so that they don't get hemolytic anemia. So there was an editorial on this, on these two papers, testing the same hypothesis, but we can see how difficult this kind of clinical research is. And interesting studies. It's important that physicians know something about G6PD deficiency. We saw this, even in Berlin, we see G6PD deficiency, perhaps initiated by fava beans, or in my case, it was somebody that took sulfonamide antibiotics for some reason. Now, the next study is just as hard, and it concerns neonatal thrombocytopenia. Now, premature infants commonly develop low platelet counts, which makes physicians very nervous because premature infants also get various sorts of hemorrhage, gastrointestinal bleeding, and they get intracranial bleeding, and they get pulmonary bleeding, and cutaneous bleeding, and various problems, and thrombocytopenia would increase the risk to bleed. Now, if the thrombocytopenia is due to sepsis or consumptive coagulopathy, probably the infants die. But the thrombocytopenia can also be caused by just poor development. And then the question is, at what level should these patients receive platelet transfusions? This is actually a pretty difficult clinical study. And so there are algorithms how to do this. And the current guidelines are, if the platelet count is less than 50,000, normal is 250,000. If the platelet count is less than 50,000, the infants should get platelet transfusions to try to decrease the risk of hemorrhage. So in this heroic study, the physicians reasoned, well, maybe 25,000 platelets would be enough. And so these infants were randomized to receive platelet transfusions if their platelet count was 50,000 or if their platelet count was 25,000. And the physicians were actually pretty convinced that the 50,000 platelet threshold would be better than allowing these children to drift down to 25,000 platelets, which would even make me nervous. So if we look at these two groups of patients, they had a birth weight of 743 grams. That's pretty premature. But by the time they were randomized to this study, they had gained about 100 grams in weight, but still 800-gram infants are very premature, and their expected development at birth was about 26 weeks instead of the 46 weeks that a normal pregnancy would be. Some of them had already had major bleeding, even intracranial bleeding. So these infants were sick, and they were randomized. And you can look at this scheme here, how difficult this kind of research is, who's eligible, who's not, whose parents give consent, and what happened to each individual infant is shown here, and how many infants were then lastly evaluated. So there 3,000 were eligible, but only 300 in each group were eventually evaluated. And what we see here, the primary outcome is death or major bleeding episodes. And the low threshold group, that's 50,000 platelets, they actually did worse than the high threshold group. So the hypothesis was tested, and the outcome was the reverse of what everybody thought. So that it looked like the kids that got the platelets at 50,000 had more bleeding episodes and a greater chance of dying than the kids that got platelets when their platelet count had drifted down to 25,000. And it wasn't on the basis of sepsis or these various things. And so here's the curves on this, and the low threshold group beats the high threshold group. And exactly how this outcome comes about isn't clear, but this is important to know because this is going to influence how physicians treat these very premature infants with thrombocytopenia. So the high threshold group, as you would expect, got more platelets. Maybe getting platelets is not good for you. And that's shown here as well. But the outcome was better in the low threshold group. So the editorialist in the New England Journal points out, surprisingly, infants in the high threshold group had a higher rate of death or major bleeding than the infants in the low threshold group. But she couldn't explain it either. And it remains unexplained. But the outcome of this incredibly difficult, tedious study is going to, I believe, influence how these young infants are treated. Now, the third paper in the New England Journal, fourth paper in the New England Journal, I probably wouldn't subject an international audience to this paper, but whatever's done in healthcare in the United States is eventually done in Europe, perhaps 5 years later. So this involves payment for knee and hip replacement. And the idea in President Obama's time was to provide a bundled payment where the healthcare system just gets $26,384 for a knee replacement, period. That's it. And if the hospital wants to make money on knee replacement, then they have to figure out how to save money by ostensibly providing less services without anybody noticing and without resulting in a worse outcome. Now, Donald Trump has tried to get rid of Obamacare, then all this would be trivial, I guess, but apparently in the United States, this was finally implemented in 2016. Various areas in the United States were faced with bundled payment models and other areas were not. And exactly how this decision was made, I don't know, but these healthcare experts tried to test to see whether or not this care for joint replacement bundled payment, whether it actually saves money or whether it results in worse outcomes. And so basically we have a treatment group, that's the bundled care units, and the control group, people, healthcare systems that weren't randomized to bundled care, and this wasn't done by a computer randomization. I don't know how the officials decided which areas were subjected to this and which weren't. But what we see here is that, I mean, the reasons for joint replacement are various. Some people, because of chronic illness, have joint replacement. Others have some sort of severe fracture because they fell from a tree or something of this nature. These patients are obviously not all the same. But the bundled payment model provides the hospital with the same outcome. So if we look at the patients in both groups, look about the same, no statistical differences between the treatment group and the control group, and most patients that require joint replacement are 75, and women are there just as men, and DRGs, sure. Fracture as a cause of the problem is the same in both groups, and the procedures that were done are different. Outcomes don't see that much difference either. So this is basically how this study was done. And what came out doesn't look very different, but actually bundled payment indeed saved a little money. Not much, but a little bit. Here we see the treatment centers, bundled payment centers, are a little less costly than the control centers. Whether or not this is clinically important, I wouldn't know, but there was some savings because of this. And then the question is, how do these savings come about? And I know nothing about medical economics, but I would think that the only way it could come about is by providing less services. And that was done. For skilled nursing facilities and long-term care hospitals and this sort of stuff, the patients in the bundled group were less likely to be referred to these services. They were just sent home. But they did as well. So I guess each country will have to decide how they're going to deal with this problem. So I think this is interesting, and probably we'll hear more about bundled care in the future. And so the medical outcomes were not different as far as I could tell, but the savings were accrued by sending the people home. The next topic is climate change. And the President of the United States has given his opinion on climate change many times. I've only listed the quotes here. I didn't include 2016 to 2018 because I needed space for other things. But this is an example of the so-called Dunning-Kruger Effect. And I reviewed this paper by Dunning and Kruger, which is a classic, last year. Dunning and Kruger were psychologists, and they looked at how people make decisions compared to their actual knowledge state. And what we see here is that the less the people know about an issue, the more they're convinced that they're right. And then as they acquire knowledge, their self-esteem in terms of whether or not they're right actually goes down substantially. And then when they indeed become experts, then their confidence again rises, but never to the same level. And this hypothesis has been tested in many subjects, including house staff physicians. And the better the physicians are trained, the more they're concerned about possibly being wrong. And the less they know, the more they're convinced that they're right. That's the Dunning-Kruger effect. And I think that Mr. Trump is an example of the Dunning-Kruger effect. So in this review in the New England Journal, what we find out, and this is global temperature across the world, not just New York City or Berlin, and these are from 3 different agencies that conducted these measurements, and indeed it looks like since 1960, particularly the 80s, there's an upward trend in world temperatures. And this could have consequences in terms of causing severe weather by mechanisms that you probably know. And if we look at across the world, 25th percentiles, it's not so prominent, but indeed, if we look at change in mean temperature, it's getting redder. And if we look at only daytime temperature, when we're awake, in some areas of the world, you wouldn't notice. Donald Trump doesn't notice, and the people in Oklahoma don't notice, but perhaps the people in sub-equatorial Africa do. And if we look at change in minimum nighttime temperature when everybody's asleep, that's increasing too. And if we look at 75th percentiles, then the results are more impressive. Now, could this have any medical consequences? And the idea is yes. Because even if the world temperature increases only by several degrees, large swaths of sub-equatorial Africa are no longer going to be able to sustain life. Same for the Middle East. And they might be coming over. And the business about malaria and these sorts of G6PD deficiency and its consequences, we ain't heard nothing yet, as they say. Now, there are different models what could be done. And what we've observed is even Model 3, where world breaks into large regional blocks and little focus at national or international level, I put this in red because I think this is what's happening now. But things can always get worse. And that's the conclusion in this important review. In this snapshot in the New England Journal, we see an example of vasa previa, which is a condition in which fetal placental vessels are within 2 centimeters of the internal cervical os. You'll remember placenta previa is this in worse. And if this is present, then a C-section is indicated, and this is an example of vasa previa, but the infant did well. And this is the lady from last week that had erythema giratum repens. This is a paraneoplastic rash, and indeed she had a gastrointestinal tumor, and when the tumor was removed, the rash slowly went away. The case in the New England Journal, I got upset about this one too. It concerns a 36-year-old man with a rash, abdominal pain, and big lymph nodes. I had no idea what's wrong with this patient, and these lab values don't help. And various tests for all sorts of things that might be associated with the rash were negative. But important in his history is this patient was from Morocco, and he'd moved to the United States 10 years before admission. Now, when I went to medical school and when I was a house officer, every patient that came to the hospital immediately had a skin test for tuberculosis and a blood test for syphilis, because these conditions were common. They're still common, but it's no longer politically correct to do these tests. So this patient apparently wasn't tested for these conditions. Could this be secondary syphilis? I would think so. I don't know what it is. Tuberculosis wouldn't immediately occur to me, but anybody that comes from Morocco, where tuberculosis is endemic, should be tested for tuberculosis. So nobody knew what this rash was. So various imaging studies were done since he had symptoms of night sweats and fever and weight loss and this sort of thing, and we can see big necrotic areas present in his liver here. What could these be? Echinococcus granulosis, I guess, or a hepatic abscess of some sort, or tularemia, or something of this nature. And he has huge axillary lymph nodes. So he has a skin biopsy. And I don't know what this is, massive round cell infiltrates, lots of inflammation, necro-inflammatory debris, the pathologist says. Reminded me of a condition that when I look at areas like this, I'm not a pathologist, so Wolfgang Schneider is going to come to the next session. He can comment on this, but I thought about, could this be caseous necrosis, which would be diagnostic for tuberculosis? So the discussant considers sarcoidosis and lymphoproliferative disorders and tularemia and things of this nature, but also tuberculosis. And there are skin conditions associated with tuberculosis. We've talked about scrofula before. This doesn't really look like scrofula, but tuberculosis can also cause skin lesions. So we finally learned that the immunospot interferon gamma release assay was done. It was strongly positive. So he had a lymph node biopsy. Good thing they sent it off for culture. Now PCR is never mentioned here, and I'm not certain why not, because that should have probably been done, but the culture eventually grew out tuberculosis. So this rash is an example of cutaneous tuberculosis. Social issue in the New England Journal, structural violence. Now what they mean by structural violence is the violence that's societal structural violence because of societal structures that subject persons to violence. And one of them, an example, is the prison system. So this poor 44-year-old Puerto Rican man who works collecting garbage and has back pain. Incidentally, in Germany, the garbage cans are raised by a machine. You don't have to get back pain if you're a garbage man in Germany. But he's a garbage man, he gets back pain, he has a lot of problems, and was convicted for some sort of drug problem and was in some sort of an altercation. And he spent 10 years in a U.S. prison where he was beaten not only by the guards, but also by other prisoners, and certainly wasn't rehabilitated in any way whatsoever. So that's the topic here. And what's remarkable is since Ronald Reagan became president, the incidence, and this is not prevalence, this is incidence of people being incarcerated in the United States has increased dramatically. And we don't have a system that's run by the government anymore. This is outsourced to companies, sort of like we've done with our hospitals, even here. So organizations, presumably like Halliburton and Blackwater, are running private prisons, and who knows what happens to these poor people. So that's the topic of this paper. Then we learned something about CAR T cells, and these are engineered T cells that have other surface molecules so that they fight tumors. And now the idea is to develop CAR T cells not against hematologic malignancies, but also against solid tumors. So this CAR T cell is outfitted with a molecule called 5HS, and 5HS enables these T cells to cross the blood-brain barrier. And they're also outfitted with something that addresses epidermal growth factor receptor. And this idea was tested in mice with a model of glioblastoma very effectively. So if we can cure the mice, we might be able to help the people. So I think CAR T cells have been around for a decade, and we're going to see engineered CAR T cells addressing solid tumors. Now in the Lancet, I could access this paper, and it concerns maternal mortality ratios in China. And they have indeed increased their healthcare system. We've already discussed neonatal mortality in China. That's also gotten much better. So we're interested in what's happened between 2005 and 2015. And it's been dramatic, because if the rate of improvement were as it had been, comparing 1996 to 2005, then all these green dots would be on the line. But instead, the green dots have been pushed upward. That means that they've done something dramatically in their healthcare system to improve this state of affairs. We can see these various provinces in China and how much better they've gotten. The annual rate of decline in maternal mortality is dramatically improved across all of China, with very few exceptions, and they have good reason to be proud of that. Now, the next paper in the Lancet concerns the treatment of stroke. And I'm not talking about acute stroke, where we would perhaps revascularization with some sort of catheter procedure or lysis therapy. I'm talking about what happens above and beyond that. And there's been a rumor that treating stroke patients with fluoxetine would somehow help them. I can imagine maybe it would make them less depressed, but I couldn't imagine that it would help stroke outcome. So this hypothesis was tested in a large number of stroke patients that were randomized to fluoxetine or placebo. Fluoxetine inhibits serotonin reuptake, incidentally, and these typical Rankin scales were applied here, and fluoxetine did not make the outcome of stroke any better. I wouldn't think it would, but it didn't. And strength, hand ability, motor, daily activities, physical function, memory, these sorts of things were no different in both groups. But what was different is that the people that got fluoxetine fell down. They also, not quite significant, tended to have more epileptic seizures, and they had more fractures. So it looks like getting fluoxetine after stroke makes matters worse, not better. Unexpected outcome in this study. Now, the next paper in the Lancet concerns a surface molecule called CD30, and that's a TNF receptor. It's called TNF Receptor 8, and CD30 signals through TRAF and various molecules. NF-kappa B activation has to do with cell proliferation. That alone might make it interesting. But the CD30 is present on a whole variety of cells, including T cells. And T cell lymphomas commonly also involve the skin. Examples are mycosis fungoides, Sézary syndrome, adult T cell leukemia causes these skin manifestations. And these T cells express CD30. Now, brentuximab not only addresses CD30, it's a carrier molecule that's incorporated in the cells. So they outfitted this antibody with monomethyl auristatin E. And monomethyl auristatin E is a small molecule that interferes with the tubulin, microtubular networks that are necessary for cells to pull apart in mitosis. So this is double trouble here for these tumor cells. If they swallow this antibody, then they release MMAE, which impairs their ability to divide. So this strategy was applied to these patients with T-cell lymphoma. And indeed, they did some better, quite a bit better compared to CHOP alone. And the antibody group got a modified CHOP, but maybe this doesn't look that clinically dramatic, but I'd rather be in the blue group than the red group in this study. And the last paper in the Lancet involves ixazomib, which is another proteasome inhibitor. It's like bortezomib, works the same, and you might say, so what? But ixazomib can be given by mouth, and the people can swallow it, which makes it a lot more convenient than something that has to be given parenterally in the physician's office. So these were patients with new multiple myeloma that were subjected to autologous bone marrow transplant, and then they got ixazomib or placebo in terms of whether or not relapse was inhibited, and it was. So ixazomib is an orally effective bortezomib, and it might help patients with multiple myeloma. Now, the next paper was in Science, and I picked it because it involves telomeres. And we've learned that telomeres are important so that cells can continue to divide, and we have an enzyme to fix our telomeres. And this enzyme is called telomerase reverse transcriptase. Works very complicated and make these nice caps on these chromosomes. So we'd like to have our telomeres fixed so that we can live to an old age. On the other hand, if we have a tumor, we'd like the tumor not to have any telomeres so the damn thing would stop growing and not metastasize. That's the argument. And the disease is neuroblastoma. Now, neuroblastoma is for children, it's a common solid tumor cancer of children. Thank goodness children don't very commonly get cancer, but this is an important tumor. And the problem with neuroblastoma, for some reason, is that some neuroblastomas, no matter what you do, the kids die. And other neuroblastomas go away by themselves. Some of them even regress and become benign tumors or just disappear. And what is going to happen here is largely, in any individual case, unknown. Now, these are neurogenic tumors. I'm not aware that they elevate blood pressure, but they make homovanillic acid, they make dopamine, enolase, and things that neurons might possibly make, so that these are biomarkers for these tumors. Now, in this paper, which is from Germany, we look at this tumor, and are there any molecular genetic markers in these tumors that might tell us which don't even need any chemotherapy and which should be treated very aggressively. And that was done in this large cohort study of kids with neuroblastoma. And what we can see, you might imagine, the rat sarcoma protein is the first proto-oncogene that was discovered. And it was discovered in a rat strain that got sarcomas. And it turns out that it's a G protein, and it's involved in MAP kinase signaling pathway that encourages cell proliferation. And we've heard of BRAF and KRAF, and these are in this RAS signaling pathway that might promote malignant disease. And we've learned about P53, and we don't want mutated P53 because then we aren't protected from tumors. And so the kids that have mutations in RAS or in P53, they do worse, and that would be largely expected. But we look at this additional information. If their TERT is maintained and they are able to repair their telomeres with every division, then these tumors are much more aggressive than if their TERT isn't maintained. And so there are TERT mutations here that involve rearrangement and tumors with high TERT activity and high maintenance. And then there's a MYC-N gene that functions, I suppose, like MYC, which is also a pro-oncogene, also gives a bad prognosis. And what we learn here is that the kids that have TERT maintenance in their tumors die off. And the kids that don't have TERT maintenance, some of them do very well and their tumors regress spontaneously. And that's the result of this study. So neuroblastomas, how they end up, is a function of their TERT maintenance, in addition to these other mutations that can occur in these tumors that have an influence on prognosis. So this may be also an insight in some additional treatment, although I don't think I'd like to give anybody a generalized TERT inhibitor because that would probably not be a good idea. Then this morning, my attention was drawn by my lovely wife to Alzheimer's disease. Being older, I'm at risk. And Alzheimer's disease, in essence, is a form of amyloidosis of the brain. And it involves amyloid precursor proteins and a variety of different enzymes, so that eventually amyloid proteins are produced that result in these amyloid deposits in the brain, which results, it's a neurodegenerative disorder. And we can diagnose this with a variety of techniques also that involve clinical testing and imaging and various things. But the new biomarker on the block is neurofilament light chain. And neurofilaments are necessary in neurons to give them their structures. And they also, there must be a neurofilament heavy chain, I assume, because neurofilament light chain even has its own gene. And as I learned in the literature, neurofilament light chain probably goes up in a whole variety of neurodegenerative diseases, including Parkinson's disease, as shown here. But in this paper that was in Nature Medicine a couple of days ago, we learned that neurofilament light chain is produced in patients with Alzheimer's disease, even before they get Alzheimer's disease. And we can see that in cerebrospinal fluid and in the plasma, about 5 years before these patients get symptoms, neurofilament light chain is up, suggesting that this might be a biomarker for patients with Alzheimer's disease. And then we have to look at where do these patients come from. And all of these patients have genetic Alzheimer's disease that get Alzheimer's disease before age 60 or at a relatively young age. And they're being studied in a large cohort in Germany so that they can be studied prospectively. Well, I think that's nice, but does this have any meaning for Alzheimer's disease in the general population, where the patients are going to be 15 years older, have diabetes mellitus, hypertension, cancer, whatever old people have? And I'm not so convinced. And neurofilament light chain seems to go up in a host of neurodegenerative disorders. So if this is going to be a fantastically successful test, I'm not certain. Then a review in JMA. We talked about post-traumatic stress disorder last time. This review in JMA talks about treatment and what the guidelines are for treating post-traumatic stress disorder. And here we see an example. I assume this young lady here is the therapist and this poor guy here is the patient. And what we learn from this is that indeed there's a unique psychotherapy for patients with post-traumatic stress disorder, which causes them to confront the problem and talk about the problem, and in multiple sessions so that they get used to communicating their problem. But I think what's important is drugs don't seem to help. As a matter of fact, several drugs make post-traumatic stress disorder worse, like benzodiazepines and risperidone makes it worse. And even the idea of giving these patients prazosin, which is, I wouldn't know why, an alpha blocker, how that's supposed to help migraines, I wouldn't know. But apparently it doesn't, so it shouldn't be given to patients with post-traumatic stress disorder. Now, before I let you go, last patient, 28-year-old woman goes to an eye clinic because she can't see straight. And she gets examined, a very nice retina photo here, and what we see here is a big infarct. So this is a vascular catastrophe that's happened to her. Here's her macula, it still looks pretty good. And here's fluorescein angiography, and she's got a big cutoff here where this major branch that's supposed to be feeding her retina doesn't work anymore. That caused these eye doctors to get a consult. And so they had some cardiologists look at this patient. I don't know if this patient was ever examined by a doctor, if anybody used a stethoscope, but what we see in this Doppler across the mitral valve is this mitral valve doesn't work properly. What we're supposed to see in a Doppler image of the mitral valve is rapid inflow and then atrial kick, and that doesn't happen. And this is diagnostic of mitral stenosis, which I think could have been diagnosed with a stethoscope. That's the story for this week. Thank you for listening.